First time in a while.
Okay, I'm recognizing Boston.
Boston, yeah, it's very hierarchical or something. I recognize you.
I know, me too. Stay watch.
That mouse is.
I know you got it. How sure are you that we actually, I know you said,
That's what I did. It bounced.
that I formally, just text you to say, let's do it.
You formally requested it because we had a meeting and the suggestion was to punt it back to assembly members,
It might be doing that.
provide direction and where the ordinance would fit, and then you came back and said, let's go with the straw man. Can we have
it's just
that
display, the
agenda
display.
It's not
piece?
mirrored, it's
Organohalogen
so if you wanted mirror
toxic
then or.
chemicals.
Well, that's
and-
always nice.
Oh,
and we can do that. So,
Soon, you will be soon.
So you can go use that display setting.
Are we on the record?
we're not on the record yet, we're just technical difficulties. Did you want to start
Sure.
while he's working on that piece?
I can absolutely start with the introductions and what we're going to talk
kept my
about.
mouth
Okay.
while the flames were burning
Okay.
behind my eyeballs.
Great.
Today at the committee meeting? You talked to the sun.
I didn't say the things that.
Yeah, you guys both are both right. That's you being quiet, and it doesn't look that quiet.
Yeah.
Oh, we are recording.
There were-
Oh, okay.
There were some things.
I call this meeting to order. This is a meeting of the Assembly Health Policy Committee. Welcome and thank you all for being here. Let's go ahead and start by introducing ourselves for the record. Mr. Dyson? would you- And
Jennifer Bundy Cobb.
Cherie Hendricks from the Wilson Agency.
Juna Penny, Director of Employee Benefits.
Suzanne LaFrance.
Christopher Constant. Felix Rivera.
Austin Quinn Davidson.
Eric Croft.
And in that,
Deanne Fetco, Health and Human Services. Natasha Pineda, Health and Human Services.
Really not Jane Kaufman.
Courtney McLaurin, Health and Human Services. Shannon Karen.
Carlos Sippin, Health and Human Services.
Drew Shannon, Health and Human Services.
and in the way back,
Elizabeth Paulson, Benefits. Steve Tom with Alaska Community Action on Fox.
okay, thank you. And it looks like Lisa stepped out. Okay, well, thank you all for being here. There are agendas in the back, and we'll go ahead and jump into our first item, which concerns management of municipal health care costs. We have Juna Penny, who will kick that off, and also to include an update on the Vera Clinic. And after that item, it should take about 20 to 30 minutes, would you say you need? We'll go ahead and turn our attention to infectious diseases, mumps in particular, and we will take a look at our next month's tentative schedule as well. So thank you.
Well, thank you very much for having us here today. Again, my name's Juna Penny. I'm the Director of Employee Benefits here at the municipality. The Wilson Agency, Cherie Hendricks specifically is our Senior Account Manager with the Wilson Agency. They are our partners and consultants in all things benefit related and a huge help to us. Jennifer Bundy Cobb is Vice President of that organization and is here with us today. She's going to give us a little more of a statewide perspective. So we're going to see kind of what's going on in the municipality and then some initiatives that are happening within the state. So our agenda today, we're going to talk about healthcare trends specifically at the municipality and then also look at high-level some benchmarks. The Assembly does have the PowerPoint presentation in print, and we won't be going a lot into the details on the benchmarking. It is included. If you have questions on it, please don't hesitate to ask us. Then we're also going to talk about some of the things that the municipality is doing to get those trends going in a different direction. So we're going to talk about Livongo, which is a partner of ours on a diabetes management program, as well as we'll talk about the Vera Clinic. And because Cherie is much better versed in the intricacies of the numbers of the municipality, I'm going to let her go from here.
Great, thank you. So there's a lot of information in this, in the materials here, and I'm gonna kind of go over and just address kind of in the materials, the areas that we've been asked, so which is the municipality healthcare trends, and you can see kind of circled there in the middle bottom, the trends that have happened for the municipality on a cost basis year over year dating back to 2005. So the trends, and I would say if we kind of just look at 2012, the trend was running about 5.5%. And in 2015, it bumped up to 22% increase over the previous year. Our costs were very high in 2015. And then they have bumped back down. So year over year expense or per employee per month, that's how we would look at this, has bounced back down. So we went from a 22% increase in 2015 year over year to a negative 10%, negative 16%, and now we are at a 2% trend increase. So there's a couple things that kind of drove the trend in those years. Specifically in 2015, we had a labor union that left, and we also had a transition that was taking place moving the health plan to Premera. And typically when members know that there's going to be a transition, they use the plan more to get their services done before the new administrator is in place. So there were a few things that happened that year, and there were significant large claims in that year. In 2016, of course, I just mentioned that we transitioned to Premera, and there's, of course, different network discounts. There's a lot that kind of goes into that, but the trend did decrease, and it decreased even further the following year. Okay. So taking a look at benchmark trends, we look at nationally. We use the Siegel. They do a trend study every year. And in 2017, on a national basis, the trends are listed up here. Medical ran at about 7.5%. Pharmacy ran at 11.5%. Dental at 4%, and vision at 2.5%. And then in 2018, you can see how those altered just slightly in each of those buckets. When I talked about the trend number that the municipality has experienced, that's an all-in across all those lines of coverage trend number. Okay. Alaska specifically, we do break out and we look at, we use Premera's trend numbers for Alaska, and medical is running about 12.8%, so much higher than the national trends that you see through Siegel. On the medical, pharmacy also running about 13.1% on the pharmacy side, and then dental 6.5% and vision at 5%.
I'm sorry.
So that's the local.
Is that growth or percentage of the thing? What's that?
That's what
percentage?
they expect claims. So a trend number in this particular instance, trend is considered a claim today. What's it going to look like 12 months from now? What does that trend look like? And it's kind of an all-in. You have a mixture of increases in expenses, increases in types of, or difference in types of services that are provided to providers, kind of new developments in the medicine, either from the provider level or the pharmaceuticals. So that's kind of what goes into a trend number.
And we have one other question.
Yes.
Yeah, thank you. So why was the choice made to select Premera as the benchmark, and is there a rationale for that?
So I chose Premera because when we look at the municipalities, there's a portion of your benefits that is covered under insurance called your stop loss policy. And when we look at the stop loss renewals and what they're looking at and putting into renewals, we're looking at, they're using their trend numbers. It's also a good representation of the state of Alaska in what they're seeing kind of across their book and what they're anticipating.
Are they the big players up here? I mean, because you use a different one, Siegel, I don't know what that is for outside numbers. So
Yeah.
Are we comparing apples to apples?
Well, may
You may.
So there's no national data source or local data source that's collecting like an all-payer database that would say this is Alaska's healthcare trend. So when professionals want to, such as Cherie, are trying to provide answers to clients such as the city, say what is the trend in Alaska, we have to rely on the carriers specifically to give us that number. And Premera has the largest population of insured people in the state of Alaska.
Great. We've also been, so what has the municipality done to address the trend? I mentioned before that we transitioned, the municipality did a big bid in 2015 for effective date of 2016. And Premera was chosen as the administrator, so that transition took place. And with the network discounts, the provider discounts that they've negotiated with the providers in Alaska, I don't know why that did that. That resulted in improved pricing, what you're paying for the services to the providers. And then we do use data analytics to find drivers of cost and address, we find programs to help address what's going on within your population to bring good programs to your members and help kind of level off those trend numbers. That's certainly the goal. So a couple things that we've done is Livongo, and I'll go into a little more detail on Livongo, the wellness program through Vera Whole Health, and then we do also monitor pharmacy as well, and make sure that prior authorizations and things like that. We just kind of monitor what's going on in the pharmacy world to make sure the formulary and all of the stuff, everybody's being good stewards of those dollars. So, sorry, I'm going through this rather kind of quickly, so please stop me if you have questions. And there's, like I say, there is a lot of information here, but what I wanted to point out, and I kind of have covered it some on this slide, is this is really taking a look at the kind of the most recent 5 years worth of trend for the municipality and kind of your year over year trend numbers for medical claims. And in 2016, you can kind of see there that we had in 2016 a 7%. So this is looking at medical only, 7% increase in that per employee per month cost. And then in 2017, that decreased down to 17, that per employee, the trend decreased by 17%. And in 2018, just looking at those lines of coverage, it's been further decreased by about 1%. When we add in the cost of the clinic that we're going to get into here in a minute, the trend is running about 3% on a per employee per month, what the municipality is spending on medical. So looking at Livongo, that is a diabetes management program that was put in place. It launched August 15th of last year. And it's really it's a great program that's out there for our diabetic population as a benefit where they can get a welcome kit. It includes their monitor, all of their test strips, lancets, so there's supplies that come with that. And it gives them unlimited coaching by phone. And if a member tests high or low, a diabetic coach will call that member and make sure and help walk them through their situation. Maybe they need to have orange juice or whatever. So they kind of walk through that, and it gives them an online access to their blood glucose readings. They can share it with their family member or their doctor and give that information. So members with diabetes cost on average $9,745 more than members without the condition. And we have here, we've identified the people in your population that have diabetes. There's about 396 of those people. We know what they cost on average per year. And I guess where we kind of want to get to on this is that we have 91 people that have signed up for Livongo, which is great participation in the first year, the launch year. And I think it's great that we have a lot of our, probably can't see those little numbers back there, but we have 52 people at a moderate risk, 25 people in a high risk, and 10 of our very high risk diabetics that have engaged in the Livongo program to help themselves better manage their condition. And then just and those are numbers through June. Through September, as of September 11th, we actually have 111 people that have enrolled and 92 that have activated their devices. So great first year launch of that program. The next phase is taking a look at hypertension. So again, our people with hypertension, a lot of times we have comorbidities, or maybe somebody just has hypertension, but we have a lot of people with comorbidities. When we look at our hypertensive population, we have 1,000 folks that have been diagnosed with hypertension, and some, through the pharmacy, we can see that they have hypertension. So this program is something that we're considering launching in 2019 for the municipality, where it's really, it gives them the blood pressure cuff, and it reminds them to check their blood pressure, keeps track of the readings, et cetera, to give them a better dialogue, as well as coaching is available for those, for that program as well. Any questions on that? No?
How many total members are signed up just in the plan itself?
Employees, we have about 1,990 employees, and we have 5,200 members. So employees and their dependents that are on the health plan.
Okay.
Yeah.
Mr. Dyson?
Yeah. Do any of our municipal employees belong to a union that has their own medical care?
Yes, but they are not. Those are not included in these numbers. These are just the folks that are on our health plan.
Yeah. How many members or union members have their own medical care separate?
There are 4 unions inside the MOA health plan and 5 outside. So IFF, operating engineers, IBEW, Local 71, and plumbers all have their own trust plans.
We've got that.
We have one other question, Mr.
Yeah,
Compton.
thanks. You kind of got ahead of me pretty quickly on slide number 6, which is the healthcare trends.
Yes.
I just want to look at the last 2 numbers, or 2 columns in the last line
Yep.
quickly. So total annual plan cost, claims, and fees for 2017 was 46, which is a pretty good reduction from the previous years. And then 26 and 18 to date. Are we on track to be about the same as we were, or lower? And this is at the point at which we implemented the Vera Clinic. And I see the bottom line there is total annual plan cost with clinic. So can you just dive into those last 3 numbers right there a little bit with detail?
Yep, I can. So the 26, so that's for 7 months, and I'd have to pull out my calculator, but if we I think we're on track to be around where we spent last year. And then with the clinic, we're just a little bit above that number. So, I mean, we're pretty on par with 1, where we projected, and 2, with where it was spent last year overall.
So
Does that answer your question?
yeah, just a little follow on then. So we spent roughly, was it $9 million to establish the clinic and get it up and running and budgeted and projected? Is that
For 3 years.
Okay, so $3 million for the year. So, okay. And we're looking at maybe a net savings of that or not? How are we kind of tracking? Or does that come up in the next part of the presentation?
Well, it does. So we have information about Vera. As far as the savings, net savings for Vera for the first year, we're way too early to tell what those savings actually are. So
We've only been open 6 months.
6 months.
So it's
Yeah.
very early to tell right now.
So last question then, the 17% reduction in net from the previous year, I'm sure you said it and I just was distracted. What did we account for that?
So one of them was in 2015, we had a union that left the MOA health plan. Effective January 1, 2016. So they were transitioning to a new carrier. And typically when you see that, not just the union, but the municipality as a whole, when someone's comfortable with their health insurance today and it's going to change tomorrow, they're going to get all the services they can today. So that number shot up in 2015 and then reduced again. And in addition to that, we transitioned from MOTA to Premera, and Premera has much better network savings than MOTA did.
So essentially the argument is the 17% reduction in 2017 is from having a better provider network.
And we didn't have as many large claims as we did as well.
Yeah.
So a little bit of luck.
Right.
Yes.
Thank you.
Yeah, it is some.
Thank
So
you.
typically in claims plans, you see every 4 years, there's a big blip in the claims. So
Thank you.
as far as large claims.
Okay.
Well, and there's also, this data is based on the day the claim is paid.
Not
So if you
when it
go
was-
to the doctor in December, it may not be paid till February or March. And that, when June is referring to the membership who left the plan January 1 or December 31 of 15, we continue to pay their claims because that's part of the obligation of the contract, those that had been incurred prior to the day they left.
Yeah.
And there were a number of more than we had originally, than historically would have been projected.
Yeah.
Okay, thank you. And Mr. Dyson has a question?
Yeah, thank you. We hooked up with one of the hospitals, this provider.
Providence is the preferred
Yes.
provider with Premier, yes.
And did Premier make that choice, or did we?
Premier does.
Yeah, I just know, a few years ago, the state went to
Regional.
regional because of cost and error rates. All right, thank you.
Okay.
So we have no input on that. Whatever, we hire Premier and they make those choices.
Yes.
Correct.
Thank you, Mr. Dyson.
Thank you. Okay, so Vera, this is the new clinic, and it's available for all Muni health plan participants. So just from an eligibility standpoint, just a real quick kind of overview of the program. The cost to the member, there is no cost for those members that are on 2 of the health plans. For the members that are on the high deductible health plan of the HSA, there's $75 for the first visit, then it's $50. All preventive visits are covered at no cost. There are 2 clinics, one on the east side, and then one in Midtown. And the Midtown is the ASD, kind of their home clinic, Anchorage School District, and then the Muldoon is the Muni's primary location. The clinic opened March 5th officially, and so it's just been 6 months. The employee incentive is $200 once they do their annual whole health evaluation, which consists of their health assessment online, preventive visit, biometric screening, and health coaching, the intro to health coaching. So just to kind of bring us all on that page. So this is a lot of numbers. I think if we just kind of look at the total column on the far right-hand side, you can see there the number of visits that we have had. So we've had 444 biometric screenings, but I think we look at 455 provider wellness visits. And we do have people going into the clinic. The provider office visit, which is the 329 there on the second row from the bottom, those are visits where people are going in for things other than their wellness visit. So those are people that they're just going in for general physician visits, which is good news. New unique visits. So this tracks our visits. How many patients have we seen each month? And so you can see kind of we started off with Gusto in March and April with 120 visits in March, 128 in April. And through the summer months, we kind of tailed down into the 70s, 70 to 80 visits per month at the clinic. When we look at total engagement, we have 12% engagement. And year one, we're at 553 is what that number is based on. So 12% of the full member population. And then we break that down into the employees. We have 24% employee engagement, or 430 employees, and 122 spouses and dependents, or 5% of our spouses and dependents have been in. This slide here is taking a look. AWHE is our annual whole health evaluation completion. So our people that have completed all of their steps to earn their $200 incentive, if you're an employee. We have had 359 people that have earned have earned their $200 incentive and done all 4 of those pieces. We have a few more that need to complete their health assessment in order to get their $200.
And Ms. Hendricks, if I could
Yes.
just pause you for a moment. We did start 15 minutes late, and we can go ahead and extend about 15 minutes, I believe, Lisa. Ms. Pineda, will that work for your team? Okay, so we'll
Okay,
try to
we're
wrap up.
just about done.
Okay, this portion of the next
Yeah.
5, thank you.
Okay. Great. So this is, we were asked where are the savings or what's been the result of the clinic to date. Again, we don't have savings information. What this slide is taking a look at is the biometric screening results to date. So what I would say is in the first quarter, we had maybe more of our healthier people excited to go into the clinic, which is often what you have with wellness programs. You get the people that, well, I'm already doing wellness and I'm really excited to see that I'm doing the wellness. And they go in and to the clinic. And I'm not saying that everybody was in that position, but in quarter 2, our stats have kind of normalized maybe, and we had a little bit more of our riskier population going into the clinic in quarter 2. So I think we're moving in the direction that we want, and to get people in and make them aware and help them with their health conditions in the clinic. The initial feedback, what is working well. So employees are very happy with the new clinic hours. That was based on feedback that we got from members. They wanted some different hours, so those were adjusted. And we do have our first employee that's willing to do a testimonial for future communications, which is fantastic. What needs to be tweaked? You want to talk about this, Gina?
Sure. So a couple of things that we've been playing with and we haven't landed on just yet, but we know we need to do additional marketing, and we continue to try to do that. We also are thinking the Anchorage School District implemented a spousal incentive to get more spouse participation. So we're talking about that. We're looking to see how much that would cost the municipality to do that. We're also looking at, right now there's a pilot program with Vera called Vera Direct. So if you can't get into one of those same day, next day appointments for an acute visit, they do have a telephonic opportunity where you can call the clinic. It's actually it's a FaceTime, so you can see the provider, you can talk to the provider, and as soon as they move that out to across all of their clinics, then we will start participating in that as well, and that will open up additional appointment times, if you will.
Right?
Now we're going to turn it over to Jennifer Bundy Cobb to give you an overall state legislative kind of view.
Yeah, and so I'll be brief, and the topic may be a little more overarching than what we intended to cover. So specific related to healthcare legislation, and even healthcare legislation down to really insurance reform and payment strategy reform, not the type of healthcare that your next group of people will probably be talking about. So I belong to a couple of different grassroots groups. One is the Alaskans for Sustainable Healthcare Costs. There's another organization known as the Blueprint Strategy Group that Sandra Heffernan has been heading up. There's a few others that are less groups and more just organizations or hearings that are being put together by people like Senator Giesel and the director of the Division of Insurance, Lori Wayne Heyer. And essentially, there's 2 areas of focus that these organizations have brought up that I'm particularly interested in. Some of them have other areas that they're covering that I'm not directly involved in. But they're related to payment and strategy reform. And one would be transparency. The municipality has certainly made big steps in being a leader in passing a transparency regulation that applies to the city, but there is now elements of transparency on the state level. Then the next push is to modify or potentially eliminate the 80th percentile rule, and I won't suffice it to say what that is. It's a form of cost comparison that's used in our insurance market that is not used in any other state in the United States the same way that we do in Alaska. And there are lots of studies that would lead people to believe that that is a direct driver of the fact that we have high healthcare costs in Alaska. There's some controversy around that statement in and of itself, but I think there's enough study, enough evidence that most people will agree that it's at least part of the problem.
I'm sorry, what is?
It's referred to as the 80th percentile, and I know we're short on time, but basically it's the way that cost insurance rates are set and the way reimbursement rates are set at the provider level is the way it's happening is, I believe, contributing to the higher cost of healthcare in Alaska. And I'd certainly be willing to send additional information on that if you'd like that. What's not on the bullet that's also being discussed is the fact that if we're going to have some payment reform, we don't want to leave members, and we're all members when we go to the doctor, and we all have insurance bills that we have to pay on our own. We don't want to leave members, such as our constituents and ourselves, with a lot of balance billing, surprise billing issues. And so Senator Giesel and Lori Winghire are also now focused on some conversation around balance billing and surprise bills. That will require legislative activity, a bill basically to pass in Juneau, and we know that can be challenging, and so both of those women are trying to get some some good support from both sides of the story, bipartisan, so to speak, support on that, and that's what's going on this fall.
Thank you.
Yep.
Mr. Croft?
Can I just say, so, I'm skeptical of the legislative or government solutions on this problem. I was there when we, under pharma lobbying pressure, passed bills to say we couldn't use our bargaining position to lower the cost of drugs. And a similar thing has happened at the federal level. It has long seemed to me that instead of the legislature or government setting or even relieving some of the relay pressure, that simply using our market, using the number of employees we have, maybe the school district, maybe other big employers, to use a market-based counter approach to simply say, we collectively have 100,000 employees or 50 or whatever we can amass together with those, and we will only pay these things or we'll fly them out or do something else. Why isn't that a better solution with the number of employees? Yeah, as I said, we have, the state has, ASD has, other, maybe business enterprises than whatever Juneau's doing.
There are many who would argue your case, and I respect that. I don't agree because we already have large purchasing programs. We already have lots of people covered under single plans, and no one yet has had enough people to be able to impact the cost to the degree that I believe we need in the state. There are well over 100,000 people in various Premera plans, as an example, and they do not have the bargaining power to affect the cost to the extent that I believe we need to impact it. And so while I'm not generally personally a believer or of government reform to solve private problems, I believe in this case the government does need to intervene.
It's hard to imagine, but I think you could get worse. Be careful what you ask for.
Mr. Dyson? Thank you, Mr. Croft.
Several jurisdictions and a couple of major insurance companies are starting to use medical tourism as a way of cutting costs. Quality can be good and the cost extraordinarily different. How in the world would we go about having that conversation and deciding whether that's a policy to think about for the future?
We do have a travel benefit within our healthcare plan through Premera, and they will assist in making travel reservations. They will help you in accommodations.
You've answered my question.
Okay.
It's already
Yep.
happened.
Okay,
you.
we're in it.
And
Okay.
congratulations.
Thank you. Now, if we could just get more employees to utilize it, that would be even better.
Yep.
Send them to me.
Okay, I'll do that.
Okay, and we will need to move on, but we have one last question,
Yeah,
Mr.
I just
Constant.
want to bring it back to the Vera Clinic and the costs that we're talking about, and just so I understand, I'm really clear on where we are. So, and I understand and put the caveat on any comment I make now that it's too early to make any global assessment because it's new. I heard you say that we need to do additional marketing to get people in. The ASD has used or is contemplating spousal additions to that $200 benefit to help expand the scope of who's using the clinic. And that if you do 200 times 359 people, that's 71,800, and I think we appropriated close to 300,000, if I'm not mistaken, on the question of those incentives, right? And so we're getting to the question, is usage at this time justifying the existence of the clinic and as a business? And if not, how are we going to get there?
So how we're going to get there is we need to get people in the door, and we've got to figure out we need to find better ways to do that. Incentivizing the employees is working. Vera tells us, and I think probably providers in general will tell us that during the summer it always falls off. In the fall it starts to ramp back up because you have school physicals, you have flus, you have all those things that come during the fall. So we will start to see an uptick there. I think in the Anchorage School District already has an incentive for spouses.
Right.
And they have an incentive for employees just like we do.
So
And it's,
the follow-on question that I very
Yeah.
briefly is, are they seeing better usage numbers than we are?
actually, I could have Beth respond to that. She came from the Anchorage School District, so she may know for us.
Hi, so my name is Elizabeth Bolsett, and I was the insurance specialist for the Anchorage School District. I've been on board from the onset with the Vera Clinic, and yes, the Anchorage School District has seen an increase in usage numbers, both for employees as well as spouses. Once we started offering the spousal incentive, our spouse numbers doubled.
So that's my question that I'm going to keep coming back to. Does the business model that we're implementing actually achieve the goal, not just from a cost perspective, but numbers of people through the door? So thank you for this. This is really good information.
Okay.
Thank you.
Thank you, Ms.
Thank
Penny.
you. You're welcome.
Ms. Hendricks and Ms. Bundy Cobb for coming. I think we'll be returning back to this topic through the course of the year. So thank you very much
You're
for the
welcome.
information. Ms. Pineda, we'll go ahead and turn the rest of the meeting over to you and your team. And I don't know if you want to start.
Yeah, I'll go
with
get
the-
started while they're turning.
Okay.
I just want to add Jennifer, because I missed
Oh.
her. So while they get set up, I'll just go through the opening. So they provided you with this packet of the slides and of materials that go along with it. Again, my name is Natasha Pineda. I'm the director of the health department. I'm on day 73. So congratulations to me. So the way this is set up is I have the introductory slides, and then each set of slides, you'll go to like tab 1 has the opening set of slides, and then supporting documentation that goes along with that. Obviously, because we have limited time, we won't get into, but the staff felt it was critical that you have that access to that information. So as we move along to a next set of slides, you may have to go to the next tab because we wanted the materials to be assigned to the particular slide that was relevant. We've included here, let me see, is that clicker working? I've only got a couple. I'm going to pop through here. You guys know our mission. It's just a reminder that the focus of the health department is really about being a leader in the Anchorage community and promoting health and wellness in the community. Through public health, we use the 10 essential public health services. You'll see this throughout our presentation, so I won't take up too much time to discuss it, but essentially most of our programs, we have 17 programs of approximately 100 and so staff that service the whole entire municipality of Anchorage, and we use these 3 core areas and these 10 essential services to guide our work. So as we start doing these presentations throughout the year, we'll build a foundation and ground you in that over the year, so that you can understand how those impact our work. So I'm going to, just for the sake of time, pass this off to our team. So our team here will introduce themselves and they'll take on the presentation. since we're short on time, I would ask if they could go ahead and get through the content, and then we can do questions at the end. And if there's anything we don't have time for, we'll obviously be available to send you written responses and follow up, and I'm sure we'll see you next month as well. So I'll hand it off.
Thank you. My name's Drew. I'm a public health nurse, Drew Shannon. I've been at the municipality for almost 5 years. So I feel really privileged to be a public health nurse. I get to do a lot of different things, both directly with patients and then community projects as a whole. A couple of my primary responsibilities and why I'm here speaking today is I serve as a immunization coordinator for the health department, and I also complete epidemiology investigation. So basically foodborne diseases and vaccine preventable diseases. I'll track people down, do any needed follow-up if people need preventative medicine, vaccinations, and see if the community's at risk and we need to put interventions in place.
And my name is Willie Mamcheng. I am the Disease Prevention and Control Supervisor. I oversee the section that Drew takes care of in terms of investigating infectious disease, foodborne, waterborne, or any sort of infectious disease. But in addition to that, I also oversee the follow-up of sexually transmitted disease and tuberculosis. And also, I joined the Muni about almost 4 years ago, and I was always passionate about the prevention of infectious disease before they happen. And so my ultimate goal was always to see Anchorage free of any type of infectious disease, because I know they can be prevented. And so I'm always very, very passionate about public health and the work we do down at the health department to prevent the infectious disease in the community.
Thank you. And my name is Carlos Sippen. I am the Clinical Services Supervisor. I've worked for the Muni now for a little bit over a year, and I'm very happy to be here. I started my nursing career over at ANMC a couple of years ago. That took me up to Barrow for about 2 years, and then served as a director of quality. And transitioning back, I really wanted to do something for the community. I've lived in Anchorage my whole life. I don't know any other place than home, and I've lived here for 29 years. So really being able to use my skills and my degree to really give back to the community is why I'm here. It's new for me, but every single day when I come in, I see the looks on people's faces, and when we get to the community, I know we're making a difference, and it's overwhelming. And I'll just jump into the slides here. So public health nurses play an essential role in infectious disease prevention and control. And the key point here is prevention really is the key for everything. We hear about it all the time. Cancer prevention is one of the big things that folks have been focusing on. And through really good preventive medicine, screening has reduced cancer. Over at the health department, not only do we help folks with prevent cancer, but we also prevent a wide variety of different diseases in general. We deliver services directly to the community. We do have a physical space, but as we see, sometimes there's some barriers. Folks can't come in, so we make the greatest effort to go out into the community and meet them where they're at. And overall, on top of that, we also look at different barriers, and we want to eliminate these barriers because, in the end, if we're able to prevent diseases, this contributes to a happy and a healthy community. So a little bit about our public health clinical services. So we are a safety net public health clinic that serves some of our most vulnerable in the community. We do not turn anyone away. Although our scope is limited compared to some other places, we do have existing partnerships to get folks to the services that they do need. In 2017, we served a total of a little bit over 14,000 patients, and that's physical space with some other outreaches, but that doesn't include, when we set up for a health fair and we're passing out information and education. We provided over 7,000 immunizations, focusing primarily on children. Children are some of the most vulnerable to diseases because they do not have the appropriate immune responses to some of these infectious diseases. So as Drew had stated, we are the authority that reaches out and responds to outbreaks of infectious diseases. We also provide tuberculosis treatment, testing, HIV, outreach and services, as well as healthy relationships and things that are encumbered in that. Just a couple items down here at the bottom. We're a small crew, 36.75 FTEs, roughly about $4 million in operating costs, 63% which comes from grants, from federal grants, 12% is from revenue, and 25% from local tax. But, you know, we don't do this on our own. So partnerships are something that's really, really important. And I just want to refer back to this quote from Helen Keller. Alone, we can do so little. Together, we can do so much. So we're not alone in this battle, because we know that 36 people, you know, being able to address a wide variety of different things going on in the community, that's not enough. So what we do is we partner with, and this is just a couple of the agencies that we do partner with. We reduce duplication. We don't want to do double of what someone else is doing. There is no competition. Our door is always open, and we have community partners come in and want to partner with us frequently. Partnerships leads to efficiencies in services. Again, if there's a community partner that's going after the same objective, it only makes sense that we show up to the table as well and be able to supplement what they're already doing. Because in the end, public health really is for everyone. It's not about any of these specific things onto the side. We look at the community as a whole, and we want to be sure that public health really is for everyone. So why are we here today? And you can go ahead and switch to tab 2. Oh, pardon me, I overlooked one slide. Okay, right here. So the reason why we're here today is, you know, the health department, we'd really like to partner with the assembly more. The objective here is I want to ensure that everyone is fully informed of the health trends and identify problems. And we are solutions focused. With these problems that we do identify, it is our objective to present solutions. When problems are identified, you know, we'd like to be able to have open conversation, look at what's going on, and our team of professional public health nurses here can certainly assist throughout that. So today we'll be focusing on vaccine preventable diseases. Quick overview. The packet does have additional information on all 24 diseases there, but there are 24 vaccine preventable diseases. 17 are routinely recommended. Of those, only 11 of them require vaccinations for children when they enter the school district or in child care facilities. I will transition off to Willie.
So on the tab 2 is your next PowerPoint presentation. And this is when we want to really state what the problem is. Because you hear about infectious disease, vaccine preventable disease, and you know it can be prevented by vaccine. So what is the problem? Well, when you look at the U.S. map right there, you can see that there are some dark spots and some light spots. The dark spots are representative of the states who have a great immunization coverage for children 15 months and older. 19 to 35 months old who are on time with their immunization. And so the state with a lighter shade of grading or lighter shade of blue represents the state who have that immunization coverage, basically. And so where does Alaska stand? As you can see, the red shows where we're standing. For the DTaP, which is a diphtheria, tetanus, and pertussis immunization, we are the 9th worst in the country. For measles, mumps, and rubella, they have heard of the mump outbreak, we're the 2nd worst in the country in terms of being on time with immunization coverage. And for the varicella or chickenpox immunization, we are the 6th worst in the country. So in order to get optimum immunization coverage and achieve a good community immunity, we need individuals to be able to access the needed and recommended vaccine on time and remain up to date with their immunization. The next page on that, on tab 2. So who is at risk? Now we know we have very low immunization coverage, but then there are some folks who can't be immunized because of some condition, and children, sometimes based on their age, cannot be immunized because they don't have a strong immune system to respond well to the vaccine. So those folks who are very vulnerable, once they are infected with a vaccine preventable disease or with any infectious disease, they are at risk of developing consequences, very devastating consequences. For example, a pregnant woman cannot get a chickenpox immunization or measles, mumps, and rubella immunization, but if unimmunized or not protected against the disease, they contract the illness, they can have very severe consequences, which include even death of the unborn child. The picture right there is from the Ted Stevens Airport, and it just depicts how much Anchorage is a big hub for tourists all around the world. And tourists just don't come to visit, they can also bring diseases. And so therefore, an outbreak can happen just an airplane away. With a low community immunity or low immunization coverage in our community, it just puts everyone at risk of being infected with an infectious disease.
Can I ask a question?
Yes, go ahead, Ms. Quinn Davidson.
So, thanks for the presentation. It's really useful. The prior slide, you were talking about statewide in Alaska, how
Yes.
bad the immunization rates. Is that skewed by more rural villages versus Anchorage, or how does Anchorage fall into that rubric?
So for the data sets that we have, we really can't pull out local data for that based on how our state system collects the data and the National Immunization Survey. The populations for each communities or regions are too small to actually give an accurate representation. So that's something they're actually working on the state level, is being able to get that data for what it actually looks like by region or even community.
Mr. Just quickly follow up, then maybe it's a Tasha question, or maybe for you. Can you take a kind of clinically educated guess about the difference between local and national, assuming that we aren't going to base any judgment on statistical representation? What's your sense?
I can only go off of what the data I have. So, I don't know as far as village versus urban. I know in a lot of our urban centers there can be little pockets of anti-vax populations, but they're not necessarily counted in the count to begin with. So they don't show up on a database unless they've had a vaccine. So most of the data is from a National Immunization Survey, which is voluntary.
And I just remembered that you asked us not to ask questions.
Sorry. Yeah. Easy to do.
But based on the number of cases of infectious diseases that you see, you can draw the conclusion that there are
Yes.
people who need, the populations that require additional immunization.
Yes. And we will get into that. Drew's got
Okay.
some examples of exactly what's going on and what's leading us to this conclusion of, regardless of what, second worst in the whole country for Alaska, I mean, there really is a problem just within the municipality.
Thank you.
And let's just keep in mind that even though we're showing Anchorage, Alaska data, we commute a lot. So whether we're showing Anchorage rate or the village rate, the population in Alaska is constantly moving. So same activities here may apply in villages. So why does this all matter? Well, vaccine saves lives and saves money. The CDC estimate that between 1994 and 2016, vaccine prevented 381 million illnesses, helped avoid 855,000 deaths, and nearly saved more than $1.5 trillion in total, with just $360 billion in medical costs. This means the cost that if somebody had the disease, they had to go to the hospital, they had to be hospitalized, and they had to be taken care of. So vaccines save lives and money, but infectious diseases outbreak are still an emerging threat. Well, this is a very graphic, this is a graphic of a true story that happens in 2011. And with this graphic, I want to kind of walk you through how an outbreak easily happens. So with this particular story, a toddler came back from visiting in Kenya, and the toddler attended a daycare for one day. And after one day, the toddler started having a rash, symptoms of measles, and infected a child in the daycare. In turn, and a couple of children in the neighborhood. Now, the toddler was unimmunized and was living in a community where there were a lot of children and parents, adults, who were not immunized. Ultimately, three children in the daycare got sick from the measles. And then family, acquaintances, they also got sick from those children who attended the daycare. And ultimately, they exposed and infected some of the individuals in their social network. In addition to that, the child was transported to the emergency room and not only got a parent or family member sick within the immediate vicinity, but they also infected individuals in the emergency room who are also responding to other ill people. Remember I mentioned the pregnant women, the elderly, folks with immune compromised, an older generation. They also got exposed and at least 4 people got sick, including the homeless population. And so this is how it just takes one person to start an outbreak of a disease. And in this case, this is a vaccine preventable disease. This could have been prevented if everyone was immunized.
Susan, we have about 5 minutes left.
I think so. I think we can probably go till about 10 till
Okay.
or so.
So you don't
Okay,
really
but-
do like the biggest points.
So this graph is more about what it looks like when you have a very strong community immunity. So on your left side, you see a community where some people get immunized and some people choose not to get immunized. And so when a vaccine preventable disease is introduced to the community, because the community doesn't have a good community immunity, then a couple of people, unimmunized or unprotected people, get sick, and therefore we end up with an outbreak. Again, folks who couldn't get immunized because of some condition are more vulnerable and end up with severe consequences. When a community has a good immunity and everyone is able to get immunized, they are able to protect the vulnerable population when the vaccine preventable disease is introduced to the community and no outbreak happens. So where does Alaska stand in terms of community immunity? For the pertussis, which Drew is going to give you a little bit more specific information about, we have a community immunity threshold of 79% when the national average, the Health and Human Services nationally recommend that we get to a 90% threshold, and a really good community immunity threshold should be 94%. And so we see similar trend with mumps and varicella and measles, where we're way below the recommended community immunity percentage.
I'm sorry.
So because of that,
Willie, real quickly, give me community immunity one more time. How is it different? It's a measure of how many we have that are.
so
immunized?
community immunity means in this area, the blue ones mean these people chose to be vaccinated, when this light yellow one, they're not immunized.
Right.
And so if someone is sick and comes in, all who are not immunized, or most of the people who are not protected.
It's a
can get
percentage of
sick.
those immunized? It's what percentage of your?
Correct.
community?
Yes, yes.
Correct.
So Lily, probably we should skip through and do this next. In the next slide there in that packet, you'll see that the level of recommended immunity, and he'll talk a little bit about it in these slides, but there's some outbreak information that we want Drew to be able to share with you.
Yeah, so just really briefly, maybe 79% sounds pretty good. That's still a C+, but we really need to be at that 94% to reach that threshold where you can stop an outbreak from spreading. So the
Okay,
79.
so when we said we're the worst or we're the second worst, but it's not like we're down to 10 or 15. It's that much of a difference that 80 to 90 makes all the difference?
It does.
Yeah, okay.
And so, we're seeing firsthand the results of that. The data from 2016, 4 times the national average for the incidence of pertussis or whooping cough. As a public health nurse who has to investigate pertussis, and I've seen countless times where a child got sick from a parent or a caregiver. This child's too young to be vaccinated. Oftentimes, adults say present differently. It's just a nagging cough. They don't know they have it. Then they pass it on to a child, where it can be very severe. Half of all infants with pertussis will be hospitalized. There's a lot more information in here, and I'll encourage you on your own time to read this story and even check out some videos about pertussis, because it can be, really difficult for young infants. Prior to 2017, we had an average of less than 1 case of mumps in Alaska. And I'm sure if you've seen on the news, we're kind of still going through an outbreak. As of now, we've had 391 cases of mumps. That's what's reported statewide. 351 of those right here in Anchorage. Many of those outside of Anchorage, they had traveled to or had some family connections with Anchorage as well. Again, I'll encourage you to read some of the supplemental information in the binder. Willie and I were co-authors in a recent journal article, the CDC's MMWR.
So really the difference between 80, I'm sorry, Suzanne, but I just want to get in my head, between 86 and 79 explains that? I mean, it's as linear, if you will, as that?
Well, there's a lot of other factors as well, but whenever you drop below that threshold, that's a chance for it to spread throughout the community. And as Willie said earlier, an outbreak's a plane ride away. That's how we had this mumps outbreak. Our first case reported they had an out-of-state visitor with mumps-like symptoms. It just kind of went from there into the community as a whole. A lot of other mumps outbreaks throughout the country we see in discrete populations, like a dorm building on this university, a specific sports team. We're not seeing that here in Alaska. It's the community at large, and oftentimes we can't find a link to other cases indicating that it's those numbers of 391 is actually larger than that, and it's throughout the community.
We have a question.
Yeah, just
from
real
Mr.
quick,
Thompson.
just an illustration. This illustrates, I think, the opposite of what Ms. Quinn Davidson was kind of contemplating, and what I would try to follow up on, that in fact it is that Anchorage is the vector for the state, and if we are having a broad outbreak, then we're sending it to rural Alaska, right? And so it's, as opposed to we're protected, they aren't, and statistically anyhow, so I think there's some evidence to the opposite conclusion.
And recently, I'm actually still working on this case, a small cluster outbreak of chickenpox at a local daycare center. 6 infants, too young to be immunized, became ill with chickenpox. Based on the symptom onset for all the kids, as well as some employees and parent, indicates that there was one source of the infection. They weren't passing it to one another, but they got sick from an employee. And following up with the administrator at the facility, just trying to gauge what the risk of transmission is, I asked, do you require staff to be immunized? Do you have records? And, the direct response was, we do not require our staff to be immunized. We follow the licensing guideline. So that's one of a big gap in our vaccine coverage is both state law and municipal code do not require child care workers to be vaccinated. Additionally, there's a kind of an area of vulnerability in 4 to 6 year olds. They're not required to get certain shots until they attend kindergarten, but they're actually old enough to start to receive them. So there's some that may be behind on vaccines. Some other states already have policies and legislation in place to have their workers immunized, and we've got a lot of other information again in the packet about Rhode Island's immunization program. And just using pertussis as an example, our incidence rate is much higher than theirs. So I bet some people are thinking, I had chickenpox as a kid. I had mumps. What's the big deal? We all get it. So the impact really goes beyond just the direct medical costs. Because they're infectious, they're required to stay out of school. So that means that a parent is going to have to be missing work to take care of their ill child. Depending on what their circumstances are, that may mean they've lost some wages. It impacts their employer, loss of productivity while the parent is out to take care of the ill child. Additionally, beyond the direct health care costs of getting treatment for the disease, that cost is also passed on to us as people with health insurance. If you think about the cost of a hospitalization due to pertussis, Premier, for example, has to pay for that. They pass the cost on to us. And then there's the cost of us as public health workers responding to it. In the middle of the mumps outbreak, I was doing 40 hours a week just for mumps, for a vaccine preventable disease, and I became known as the mumps man. And I don't want to be the mumps man. I want to be a public health nurse. There's many hours devoted to mumps that could have been focused on other health promotion and prevention activities. So $1 spent on vaccines, means a lot in savings. The CDC estimates, and this was data from 2009, that $1, result in $3 in direct savings and $10 for those societal costs, which we talked about, missing work, the economic impact. And then for a single case of measles, so this wasn't an outbreak, just one case that had to be investigated, and prevention measures put in place in Kentucky in 2011 was estimated to cost $25,000 in public health response just for one case of measles. So really, it's more than just about health and the disease. It's about the economy and the community as a whole. It's can create a real big impact.
And we are approaching, I think, the end of our time limit. This is clearly very important and really helpful information, and we'll want to pick up this conversation starting with infectious diseases in our October meeting. And definitely, we didn't get to the part about concrete action, and I don't know if you want to maybe wrap up with where to
Let's
real quick.
jump to those two main
Sure,
ones. The two
sure.
main ones we're going to be working on immediately.
Yeah,
Okay.
so, ideally, we feel that all individuals who serve the public at large should have a policy in place that require vaccinations, because again, it just starts with one. Immediate recommendations, the direction of our director here, we want to pave the way to success.
We do not actually currently have in place at our department, so we'll start with us.
But we'll be, implementing a comprehensive policy that requires appropriate immunizations for DHHS employees. So, start small and really pave the way to success there. And a couple of the other things for recommendation, please review the municipal child care code. I had taken the liberty of adding that in at the end of these slides right here with some highlighted points. Definitely exploring the different opportunities for a more robust vaccination policy for both children and adults. And then again, developing a recommendation to amend 16.55. In short, the only thing that is set in stone is general adults that are working in child care facilities. They don't require any type of vaccinations. They don't require any type of check. It's not built into the regulations. There are small sections. If you are a junior that is technically a pediatric worker that's working for a child care facility, you are required to get immunizations. And the second part to that is if a child care facility is authorized to be able to take care of sick children, they are required to get vaccinations. Only two, and not the ones that we're dealing with. So definitely a lot to kind of think about. I think the intent of this policy was to keep the kids healthy, but a couple things had fallen through. But definitely, it doesn't address exactly what's going on in the public.
So we'll probably be coming to you guys with amendments in the future. It doesn't that's the main thing, in addition to our own policy.
Okay. Well, thank you very much for this information and the work that you're doing to keep the public safe. We will start up with this topic in October, and hopefully too, we'll have a conversation about toxic chemicals, fire retardants in the orthohalogenic class. Did I get that right? Orthohalogens, okay, in October. Do assembly members have any questions or comments, Mr. Constant?
Just wanted to ensure we get a report from the state misuse of substances, because they have a quarterly opioid epidemic update, and I would like to have a presentation of that. Just keep tabs closely on that.
We did have an urban fellow to start at the Department of Health is going to be doing a community assessment on opioids and other substances abuse in Anchorage. And we'll be coming to you guys with that, so maybe we could do a little bit of an update in the October 8th. if you want.
Thank you, Mr. Constant. Actually, we will be starting each meeting with an update from the director. We didn't have a chance to give you time to introduce that yet, but I know you have a dashboard, and keeping tabs on what's going on with opioids and the response is definitely a part of that.
Yep.
Any other comments or questions? Oh, was there anyone from the public who had intended to speak today? No? Okay. Okay, thank you all for attending. We are adjourned.
True.